Ms. Chiara Retis to talk about rehabilitation. She has 20 years of experience of working in non-government organizations in low-resource settings, providing capacity-building services in the field of physical rehabilitation and supporting policy reform and practices for the integration of rehabilitation into health systems. Ms. Retis is currently based in Cambodia as a global coordinator for humanity and inclusion within the ReLAB consortium. To unmute.
Thank you.
Thank you.
Good morning, good afternoon, good evening, everyone. Thank you for having me today. I'm going to provide an overview of leadership for rehabilitation in health system, why it is important today, and what are the different roles of different stakeholders who are involved in leadership globally. So rehabilitation is under prioritized today, despite the clear benefits that rehabilitation services and assistive technology services have. Many governments in low and middle income countries do not invest in rehabilitation services, and as a result, there are shortage globally of rehabilitation professionals. Services are not accessible out of the cities, for example. They are not affordable for the majority of the population. The quality is poor. Data about rehabilitation is lacking, which doesn't allow to identify gaps and set priorities for planning. And also rehabilitation services are split across health sector and social protection sectors. So the result is that the rehabilitation and assistive technology unmet needs are huge today. More than half of people who live in low and middle income countries who would benefit from rehabilitation services do not receive them. In particular, people living in marginalized communities or people living in conflict-affected settings, for example. So rehabilitation needs leadership today, really needs leadership. Leadership is one of the 6 core components of health system strengthening, according to the WHO framework, together with the service delivery, workforce, health system information, availability of supplies, medicines, and products, and workforce. So leadership and governance together are essential for a strong health system. Health leadership, what is the definition of health leadership in a health system? Leadership in health system means being able to identify priorities for planning, but also to provide technical guidance for policy development, to track changes and being accountable for the services delivered to users. It requires then mechanisms of governance for accountability, as we said, and to track the performance of services. So leadership is particularly needed today for rehabilitation because it can really support the development of strategic plans at the national level, providing strategic direction through the development of national plans. In order to do that, knowledge and data about rehabilitation are essential because they not only inform the planning of policies or programs regarding rehabilitation and assistive technology, but also they allow this tracking of performance, as we said, for accountability. This is why ReLAB-HS is working to strengthen leadership skills within the health sector for a wide range of actors within the health sector, so from policymakers and decision makers to administrators of health facilities down to the primary healthcare providers, but also leadership is needed for non-health sector actors who are, as we said, essential for any planning for rehabilitation. For example, the Minister of Finance, Minister of Planning, and academia in order to support with evidence and knowledge. Communication specialists also to help frame and communicate about the importance of rehabilitation services. ReLAB-HS, for example, will also work in the implementing countries to strengthen the health information system, which is core to provide visibility, monitoring, and tracking of the performance of services. Also to do some calculation of costs, costing of rehabilitation services to help monitor the return of investment, and then hopefully help mobilize and allocate resources that are today missing for services. This activity will also work with the representatives of users to engage them in the identification of models that work in increasing the access to rehabilitation, in particular at the community level. We have mentioned the importance of health ministers to lead and provide governance and stewardship for the development of policy and programs. However, a strong leadership is effective when it is based on strong collaborations, intersector collaborations as well, and building alliances with health, non-health actors, but also government, non-government actors. Among the non-government actors, we have the for-profit and the not-for-profit groups, which leads me to talk about an important concept that we're gonna see many examples of this today about collaborative governance. Collaborative governance is a term that is used, is referred to study and the practice around intersector collaborations that we said they spread through different types of sectors. There are several examples of collaborative governance. I can mention one, for example, in Tajikistan in 2010, following the polio outbreak. The Ministry of Health, with the support of the WHO, carried out a situational analysis around rehabilitation services that led to the development of a national program that was done in consultation with a big group of actors, the ministries of Tajikistan, 22 ministries, United Nations organizations, donors, non-government organizations, national and international, associations of professional organizations, and representatives of users. So this big group of actors was organized around the steering committee that allowed the design and the implementation of this national program. ReLAB-HS has just launched the Global Rehabilitation Leadership Institute, GRLI, which has three main objectives: to strengthen the leadership skills of stakeholders who have a role to play in the development of rehabilitation services in countries. The second objective is to develop a shared vision around rehabilitation, why rehabilitation is important as an essential component of the health sector planning. And a third objective, to provide opportunities of mentoring to this group of stakeholders that gather together to expand and build around this common vision. The first offering of the Global Rehabilitation Leadership Institute has been concluded just a few days ago in Uganda. There were 58 participants coming from 5 different countries. They were invited to spend a week together to be trained, but also to develop, as we said, a common vision around rehabilitation within health systems. This group of stakeholders or actors do represent all those groups that I have mentioned earlier. So representatives of health sector officials, decision makers at the high level, health facilities, administrators, but also frontline workers, primary healthcare workers, and then representatives of non-health sector, for example, ministries of finance, ministries of planning, academia, communication experts and journalists, representatives of persons with disabilities and service users. So the vision around working together and developing this network, informal network of stakeholders, is really to build a group of champions in each country that will be able to further work on this vision around the rehabilitation and actually lead to real changes in policies and in practices in countries. Hopefully, this cohort of stakeholders, they will be accompanied in the future to become a community of practice. We said that leadership is important for rehabilitation, and this applies for any setting, including countries affected by conflict. We know historically that rehabilitation and assisted technology services have been established to respond to the needs, rehabilitation needs of survivors following conflict. However, the presence of these services, who are also services of a good quality, might have some difficulties in being integrated as essential services within the health sector, as many other essential services that are part of the health sector planning. Why is leadership so important also in unstable and conflict-affected countries? Because it can really support the operationalization of the nexus. That means making sure that some guidance and leadership is available and continues to be available throughout the phases from development to humanitarian response to recovery phases. And I would say it's important also for countries who are, for example, prone to disaster, where preparedness plans for rehabilitation and AT services, together with the response plan, really needs very strong collaborations with all the existing stakeholders, not only to optimize the response, but also to build on a common vision in a sustainable way in the long-term perspective. So I would like to share one example of this collaborative governance throughout the nexus. With an example from Nepal. Nepal was hit by an earthquake in 2015, both in the capital and in mountainous and remote districts. There was the activation, in this case, of for the first time, of a rehabilitation subcluster that allowed the coordination of the work of existing actors engaged in rehabilitation already in country, both from the government health facilities, Ministry of Health, of course, non-government rehabilitation providers existing in country, rehabilitation professional organizations, representatives of users, and of course, international agencies already in country and organizations who came to help with the response. So the presence of this subcluster immediately activated, because it was part of a preparedness plan under the leadership of the Ministry of Health, allowed not only to respond in a better way to the needs, but also to create already a common vision around rehabilitation, the importance of rehabilitation and assistive technology services within the health system in Nepal. So in the immediate response, but also in the medium term, and then in the long term. In the medium term, for example, for the first time, to allow the continuation of services to earthquake survivors, the first physiotherapy units were established in government health facilities at the district level in a mountainous district of the country. After this, the group of stakeholders and this collaborative governance allowed the strong advocacy and actions also by all the actors, and in particular non-government actors under the leadership, of course, of the Ministry of Health. I would like to mention as an example the role of the rehabilitation professional organizations who were involved since the beginning in the response through their directory of professionals, but then continued with strong advocacy to ask for the integration of rehabilitation within the health system. After 3 years, for example, and I'm almost finished, yes, I am towards the conclusion, the rehabilitation association, they were able, for example, to achieve the integration of physiotherapy services within the essential health package of Nepal. Today, in 2022, in Nepal, there is also, for the first time, a rehabilitation and disability unit under the Ministry of Health that is led by a group of managers that are rehabilitation professionals. There are other examples of tools for governance at the national level that were developed through the advocacy and the action of non-government organizations present in country. One example for whole today is the existence of the rehabilitation module in the ReLAB-HS in Nepal. So a health sector instrument that integrates rehabilitation data at the national level. So to conclude, this is an example of how national champions, local champions under the leadership of the Ministry of Health were able to really develop tools and policies throughout the nexus. Thank you very much for your attention. And I give the floor to the next speaker. Thank you.
And very informative. Our next speaker is Mr. Alex Munyambazi. He is the founder of the Amputee Self-Help Network. He is an advocate for landmine survivors and disability rights, a medical laboratory scientist by profession, and also a rehabilitation and victim assistance expert. He is a member of the international campaign to ban landmines in Uganda. Alex will provide testimony about his experience in accessing rehabilitation and assistive technology in the context of where multiple challenges and factors intersected and shaped his experience within the country. So Alex, over to you.
Hello, thank you for that introduction. I would like to start by telling us a small story about myself. I enlisted in the military as a young man, and when I enlisted as a footballer, as a very sports oriented person, I loved football so much. And as I served, one fateful evening, I ended up losing my leg to a landmine. At the time, I was in the hospital, I didn't know the significance of timely rehabilitation, timely mental health support, and all that. I didn't know how much that can help. So I was sent to the hospital, surgeries were done, I recovered from the wounds, and off I was sent away. But dealing with the outcome of the injuries was the hardest period. The wounds healed, but the mental aspect of it was the hardest. And I give this story because this is what I've experienced with most of the people who need rehabilitation that I meet, that I've worked with, that have provided peer support with, that have helped to get assistive devices. We often think of rehabilitation as just the services given, and rather than looking at it as treating a whole person, giving a whole person the services that will help them be whole again and thrive in life and be productive in their communities. But when we talk about mental health and rehabilitation, I believe it's very important that we make sure that they go hand in hand as we plan to integrate rehabilitation into the health sector in the different countries. It's very important that we also look at the aspect of peer support and include it in our planning, because peer support plays a very big role in rehabilitation, mostly those who use assistive devices. When we talk about the challenges of accessing rehabilitation services and assistive technology, there is an issue of accessibility, whereby in most countries, most especially developing countries, you find that even the centers that provide the services, which are most of the times private facilities and sometimes NGO facilities, you find that they are mostly located in the city centers. And yet the users are mostly financially incapable of traveling from one place to another, to the extent that even when you work out a plan and you say, I'm going to help you acquire a device, they still cannot afford to transport themselves. So there's a big challenge of accessibility as we plan for all this, as we plan to integrate into the health system. we should ensure that these services are provided all the way to the community levels. Then, of course, as we plan, the users still need to have these devices available, but there is an issue of prices. Prices are too high. Even when you're able to get a device, most of the times they are not affordable to many of us. So we need to plan to ensure that we see that people get affordable and quality services, because this is what separates someone who needs this device from the other person who is not disabled. Then we also need to focus on providing the right services to the people who need them, because I say this because in my experience, I've seen most of things that mostly here we speak of for Uganda. There are people that come and they are donating, maybe prosthetics, maybe wheelchairs. And because they don't do assessment first, you find them giving 80 to people who actually don't need it, or sometimes giving someone who needs, but you're giving them a device they are not going to be able to use because right assessment was not done. Then in my experience, I have learned that we should look at rehabilitation, as I said earlier, as something bringing back someone to life, to do at least whatever they would have loved to do in their lives, be it going to school, being participating in sports, doing anything they want. So as I conclude, this is how I look at rehabilitation. I would love to enter into a rehabilitation facility. And even before I enter the center, I know that I look at it and I know, yes, this is set up to take care of me. I would love to reach there and get the best services I can. Because, for example, I use a prosthetic leg. I don't know whether any of you can go into their closet and say, today I'm putting on this trouser I hate. I don't think you can do that. So I would love to get a device that I'll put on and walk around proud and forget about what happened, forget about the lost pieces, forget about what I lost, and put on something that I feel, okay, this is not a real leg, but I'm comfortable in it. It is helping me to do ABCD, and it's beautiful. And then we also need to look at the fact that for example, in Uganda, most of the people who need, let's say, devices, prosthetics and all that, most of them have lost their legs when they are mostly working. And as they do, you realize most of them are casual workers. And when they lose their legs, they feel like their life is ending there. And we need to give them the right services. But also, when we rehabilitate them mentally and physically, then what? What is their next plan? Because someone was maybe riding a motorcycle, someone was maybe a farmer, someone was a factory worker, and now they can't do anything. So in my thinking, I think we also need to task the government to ensure that there are services given to these people to ensure that they get skills, because most of them, when you meet them, they don't want to live on handoffs. They don't want to live their lives begging, and yet they have families to provide for. So I think we also need to task the governments, the countries we live in, to ensure that we have enough institutions that also train these people in skills and ensure that they are thriving in their countries, ensure that they are participating economically, and also paying taxes like everyone else. I will leave for now with this. Thank you so much for listening. I will leave the floor to the next speaker.
Thank you, Alex, for those insights and for sharing your experience with us. It's much appreciated. Our next speaker is Mr. Sergey Komchenko. He is the Ukraine country coordinator for ReLAB. Sergey has more than 20 years of experience in technical assistance and humanitarian response management. He will illustrate to us the current situation in terms of rehabilitation needs and the gaps in the country, and provide us with an overview of how the humanitarian response in integrating the delivery of rehabilitation services and assistive technology is unfolding in the country. So Sergey, over to you.
Thank you, Nugba. Can we have a presentation, please? Valentina? Okay, thank you. Dear colleagues, in this presentation, I would like to discuss with you the magnitude of the war in Ukraine, how it is affecting the country and its rehabilitation and IT sector. What's the current situation in terms of rehabilitation needs and gaps in Ukraine? How is the humanitarian response integrating the delivery of rehabilitation services and assistive technology? Next slide, please. Pre-war context. Just before the full-scale war started in 2020-21, Ukraine faced swift, progressive changes in its rehabilitation landscape. Two fundamental studies were implemented by WHO, including a situation assessment of rehabilitation, STARS, and assessment of assistive technology. Ukraine passed a foundational law on rehabilitation in healthcare and started its enactment through several regulatory documents. In the eve of the invasion in January-February 2022, WHO and my program, ReLAB-HS, jointly developed and provided to the Office of the President of Ukraine zero draft of the National Rehabilitation Action Plan. Yet, STARS and other assessments clearly stated multiple gaps, including the following: lack of single central document that would guide clear vision and plan for rehabilitation development that included all relevant ministries, agencies, and stakeholders. This means fragmentation of rehabilitation, not only now, but in the near future. It was and still is compounded by fragmented financing of rehabilitation services via several ministries and agencies such as Ministry of Health, Ministry of Social Policy, Ministry of Veteran Affairs, National Health Service, and regional budgets. Funding of assistive products was not included in the rehabilitation packages. Patients that were out of hospital care could not get assistive products prior to receiving their disability status, as they are not included in the government-supported packages of medical guarantees. Lack of rehabilitation services at primary and community levels. We still do not have even clear understanding of what is the community level. Inadequate regulation of the rehabilitation workforce. This includes a lack of licensing, issues related to education of specific professions, and their official recognition by the Ministry of Health. Next slide, please. Facts about Russo-Ukrainian War 2022. A full-fledged invasion of Ukraine by the Russian Federation started in February 2022. It is internationally considered a war of aggression and the largest military assault on the European states since the Second World War. The war has caused the largest refugee crisis in Europe since then. As of September 14th, in its latest situational report, UN OCHA stated that 7.3 million of Ukrainians left the country, while over 7 million became internally displaced. As of September 11th, almost 6,000 people, including hundreds of children, were killed, and almost 8.5 thousand injured. This is carefully triangulated and very conservative UN data. Ukrainian statistics is much higher. Based on recent WHO estimates, about 14.5 million in Ukraine need medical health assistance. Next slide, please. Attacks against health system in Ukraine. Here's a screenshot of the WHO surveillance system for attacks on healthcare. It shows confirmed cases of attacks in Ukraine since February 24 this year. WHO has verified 550 incidents of attacks on healthcare, causing 100 deaths and 129 injuries of both medical personnel and patients. Most of the strikes have been caused by heavy weapons such as artillery, including cluster munitions and missiles. Next slide. This photo is just an illustration of such attacks reported by the world media. Regional Children's Hospital in the provincial capital, Mykolaiv, was hit by Russian forces on April 4th. As a result of chaotic shelling affecting 2 cities, killed was 1 child and injured 2. The ambulance station of the Children's Hospital received a direct hit and was ruthlessly damaged. One of our project key stakeholders, the Ukrainian Research Institute of Aesthetics, left Kharkiv because its facilities were severely affected by shelling. Now the institute works in central Ukraine. Next slide. Overarching gaps of the health system in Ukraine severely affected by war are multiple. Just to name a few of them. As we discussed, health clinics, pharmaceutical production and storage facilities have been destroyed or affected. Back in April, the chief of the Luhansk Oblast State Administration, Sergei Gaidai, stated that the Russian military destroyed all medical institutions and hospitals in the eastern province of Ukraine. By now, the situation in the affected areas has only worsened. Based on the IOM data, over a quarter of people living in villages in Ukraine don't have access to operational medical facilities. For the displaced people currently living in villages, this figure rises to 30%. At the end of July, ReLAB-HS key informants reported concerns surrounding access to healthcare services in 16% of the assessed settlements. In 12% of settlements in affected areas, ReLAB-HS key informants reported that most people did not have access to healthcare facilities during 2 weeks prior to the data collection. Next slide. As of now, we have a limited data on access to rehabilitation in affected areas. However, it can be even worse in comparison to the health facilities in general, because some were reprofiled, some workforce moved to cover urgent needs. A number of facilities, such as 8 former sanatoria in Odessa Oblast, stay closed because of proximity to the front line and overall danger to their patients. Some rehabilitation workforce was externally and internally displaced and mobilized to the defense forces. In general, the workforce was not fully prepared and trained for prevailing war-related conditions, including polytrauma, burns, and amputations. Because the health facilities are most affected in the frontline areas, early rehabilitation services are limited in those regions, and the stakeholders have been working on establishing adequate rehabilitation service along the evacuation routes. As we discussed it above, assistive technology was not fully integrated in the rehabilitation prior to war. Underdeveloped assistive technology service delivery system, lack of assistive products in healthcare facilities is still a feature that many actors such as WHO or Momentum for Humanity are trying to address. WHO and Momentum assessments reported insufficient number of rehabilitation facilities and specialists for growing needs. Next slide, please. When the invasion started, UN re-established its cluster system in Ukraine to improve humanitarian coordination. Effective coordination ensures less gaps and overlaps in the assistance delivered by actors. WHO leads coordination through the health cluster. Trauma and Rehabilitation Technical Working Group was established with a specific emphasis on rehabilitation and AT. Even more targeted coordination is achieved through the government plus rehabilitation operations partners bi-weekly meetings, also led by WHO. Finally, USAID has established and leads the Ukrainian Rehabilitation Discussion and Coordination Group. While the government actively participates in the coordination mechanisms, it is continuing health reform through recent changes in the legislation. Despite the war, Ukraine is actively reforming its health system. One of the urgent issues is operationalization of hospital districts. They are based on the cluster principle of territorial availability of quality medical care for the population. Changes were also introduced to some legislative acts of Ukraine regarding increasing availability of medical and rehabilitation assistance during the period of martial law. However, resources of the government remain scarce, while there is a growing response from the international community. Multiple humanitarian responders came to Ukraine to beef up the rehabilitation sector. Just to name a few, ICRC, Doctors Without Borders, Humanity and Inclusion, and Momentum Wheels for Humanity. Donors, including ECHO and BHA, are funding new initiatives. One of the recent instrumental projects is Swiss-sponsored war trauma rehabilitation in Ukraine. Next slide, please. One of the paramount questions we should ask is how the humanitarian response is integrating the delivery of rehabilitation services in AT. First of all, it is done through coordination of donors, government agencies, humanitarian and development implementers and providers. To inform relief activities, changing needs and capacity of the rehabilitation facilities and assistive products providers have been assessed by various actors, including WHO and Momentum Wheels for Humanity. Training rehabilitation workforce is what have been requested by the government and professional associations. Offline trainings were offered by Humanity and Inclusion, Momentum Wheels for Humanity, ReLAB-HS Global Rehabilitation Leadership Institute that Chiara talked about in her key speech, and few others. With support of ReLAB-HS, 37 online courses are now translated into Ukrainian, while 500 more available in English and other languages and offered through Physiopedia Plus e-learning platform. Humanitarian actors have been supporting service delivery at the hospitals throughout the country. Some of them are specialized on specific conditions, such as the hospital in Kleven, Rivne region, or Territorial Medical Union in Lviv. Providing rehabilitation specialists for mentoring and supervision, seconding experts to the Ministry of Health is either planned or done by WHO, the Swiss Development and Cooperation, and ReLAB-HS. Next slide, please. I'd like to finalize my presentation with conclusion and action points. Ukraine is going through the existential phase of its history. It's on the brink of survival as the state and the nation. Every aspect of health and life is impacted big time. There is no full understanding how long the war will continue and how deep the crisis will get. Rehabilitation and IT were not fully prepared for this war. They need further strengthening by integration into health system, developing all building blocks of the health system. Concerted efforts need to continue to address surges in patients' numbers, overcome workforce capacity limitations, lack of equipment and assistive products, and treat complex clinical cases. By working through humanitarian access and by assisting frontline workers, actors can strengthen early rehabilitation. This requires further efforts in training the workforce and potentially supporting it with mentoring and supervision. Finally, one piece that we don't really think of or support enough collectively is a telerehabilitation platform with a strong IT component. This platform would really allow us reaching out to areas hard to access to otherwise. Thank you. Over to you, Nugba.
Thank you, Sergey. Thank you for all the points that you've raised and the commendable work and the challenging environment within which you've been able to gather this information and share. So thank you so much for that. We will now move towards the second part of the webinar today, which is where we will have three of our panelists talking about different questions that have been posted to them. We have Professor Cyrus Engineer from the Johns Hopkins Bloomberg School of Public Health. He is a professor of practice of public health and has extensive experience as practice leader in leadership and health system performance management. We then have Mr. Myet Win from Burma. He identifies himself as a person with physical disability and works and advocates for the rights of persons with disabilities in the country. He is the president and founder of Shewa Minto Foundation in Myanmar, or Burma, which mainly works to deliver comprehensive services to persons with disability throughout the country. Our third panelist is Mr. Peter Skilton, who is Rehabilitation and Emergencies Focal Person for the World Health Organization. He has over 12 years of experience and has worked as a team member on rehabilitation response during emergency, including conflicts, displacements, earthquakes, outbreaks, and cyclones. And his mission, he has recently been in Ukraine working on a WHO response in the country. So we'll get started with the panel, and the first question that we have is for Professor Cyrus Engineer. Cyrus, if you can talk about what are, in your view, the key steps that are needed to strengthen leadership to develop health systems that are resilient. You have about 6 minutes to respond to this question. Thank you.
Good morning, good afternoon, good evening. I hope you can hear me.
Yes, we can. Thank you.
Okay. Well, thank you, Nukpa, for the introduction and for the question. I'll do my best in the next 4 or 5 minutes to address this question. And the question again is, what are my views on key steps to strengthen leadership? Because we heard that leadership is important to develop resilient health systems. Before we do that, I think it might be useful to be on the same page as to what we mean by resilience. So resilience is about dealing effectively with shocks within a system. A shock is defined as extreme change that impacts on a health system. The key operative word being extreme change. Shock is different from predictable health system stresses caused by issues such as an aging population or cyclical needs like anti-malarial drug or hospital bed shortages during monsoons when mosquitoes tend to breed. Shock is also different in that it has a sudden onset and often a surprise, and causes significant large-scale disruptions and disturbances, uncertainty, anxiety, and a feeling of helplessness. So resilience is about getting back to the original state when faced with shock and learning from these shocks. To provide an example, a resilient health system is able to take care of immunization, antenatal care, and outpatient services, which are routine, and simultaneously handle the shocks presented. Routine healthcare services were compromised and suffered significantly when several nations shifted their focus and resources to the COVID-19 pandemic. Now, getting to the key steps, which is the question. So we've learned about shocks. We know that resilience is about rebounding to these shocks, taking care and getting back to the routine services, but also addressing the shock simultaneously, as was mentioned by Kiara in Nepal. You know, the key steps, what are the key steps to strengthen leadership to build resilient health systems? As we all know, leadership and governance is a key construct, a block for the WHO building blocks. And so what are the key steps? I think the first thing that comes to my mind is the need to have leaders understand and appreciate systems thinking and the need to work outside their silos. The pandemic taught us lessons on the interrelatedness of sectors and the dependence of the health system on other sectors. Optimizing the system requires leaders to work on the parts and the whole and not just limit their focus to the health system. This was also explained by Kiara. The need for intersectoral work requires leaders to get out of their comfort zones. Leaders need to be trained at all levels to negotiate and create win-wins. While optimizing parts within the health system are critical, resilience requires hard work outside the health system as well. Understanding the nature of conflicts and how to deal with these effectively is another competency required of leaders. Recognizing that not all conflict is bad, functional conflict can actually bring about good solutions. Adaptive, agile, and distributed leadership are requisite to strengthen resilience. Health systems currently have rigid structures that are typically entrenched in bureaucracy. Resilience at developing teams and coalitions that are motivated and passionate to deliver. Interdisciplinary multi-sectoral work requires leaders to have a vision, also mentioned by Kiara, and not just have a vision, but be able to communicate the vision, convince stakeholders of the value of achieving the vision, and empower people by providing them resources and tools to deliver. Leaders need to walk the talk They need to role model and develop culture and shared values. They need to know how to motivate and influence people. There are several motivational theories in literature that suggest that different people are motivated differently, and using the same motivational theory on different audiences may not work. Lastly, leaders need to be adept at the art and science of driving and sustaining change. Change management or change leadership is key, given the need for resilience. There are several change theories and change frameworks. Leaders at all levels would benefit from training in this science. I'd like to end with a quote to emphasize the importance of this competency, the need to lead change, by the chairman of the World Economic Forum, Klaus Schwab. He said, into quotes, "Gone are the days of big fish eating small fish. In the post-crisis world, fast fish will dominate and the slow fish will die." Thank you.
Thank you, Cyrus. Thank you for your thoughts. Our next panelist is Mr. May Towin. If you can unmute the mic, the question that we have for you is, in what ways are rehabilitation services continuing to be provided in the context like Burma, where there is unstable political and humanitarian situation? You have 6 minutes to respond to the question. Thank you.
Thank you. Thank you. Good morning, good afternoon, good evening, everyone. First of all, I would like to say thanks to the organizers and the audience for giving me an opportunity to be here today. Today, I'm going to share the methods of what are current situations in Myanmar, how the current situation affects the rehabilitation health system, and how rehabilitation services are delivered to reach the most vulnerable group in Myanmar. Regarding what happens in Myanmar, I'm sure that you have already heard and seen about Myanmar through social media or your Myanmar friends. The Myanmar military seized the power of elected democratic government by force on 1st February 2021. And we all, Myanmar citizens, started facing the changes and challenges since on that first day of it. Several protests began on 5th of February in opposition of military coup. The civil disobedience campaign in Myanmar comprises a wide range of forms and many civil servants, government staff involved in the protest with the forms of civil disobedience movement by not going to their offices, their stations, not doing anything related with the job. Among them, they had the education sector have the highest volume of CDM participation. At the time, it was almost about 90% of the total number of healthcare workers reportedly joined the CDM in the first month after the coup. It impacts highly on the public health services, including rehabilitation, especially on the poor and vulnerable groups of Myanmar. Still, most health workers are still practicing CDM today. If we look back on the time before military coup, regarding the rehabilitation workforce, there were 229 physicians, 1,453 physiotherapists, 2 occupational therapists, 17 prosthetic orthotics, 25 social workers in Myanmar. As percentage coverage, 60% of the tertiary hospital has physical medicine and rehabilitation department. 80% of tertiary hospital have physiotherapists. 43% of tertiary hospital has physical medicine and rehabilitation department. 76 of the secondary level hospitals has physiotherapists, and 60% of the government primary care facility had physiotherapists. 233 beds are only available for the rehabilitation of the population. National Rehabilitation Strategic Plan, Monitoring and Evaluation Framework, drafting workshop could be conducted, finalized and launched in September 2018. Why I'm sharing this information to the audience, that I would like the audience to know where and how far we reach for hospital rehabilitations. But after medical, as I have already said earlier before, 90%, almost 90% of the total number of healthcare workers reportedly joined the civil disobedience movement, including the rehabilitation sector. So we all can imagine how Myanmar health system and public health services, including rehabilitation, are running in functioning position or not. Due to the higher inflation of the and frequent order of foreign exchange currency exchange policy by the Central Bank of Myanmar, the living expenses are higher a day after a day, and even the prices and assistant devices reach double and cannot buy them easily due to out of stock, and they cannot be imported easily. As medicines and medical equipment could not be imported easily, prices are so high and difficult even if we can afford to purchase. Grassroots people are not being covered basic healthcare services now, and quality healthcare services are so far to reach. Although there are some organizations which provide the tele-rehabilitation services, it is not accessible for most of the grassroots people due to uneasy access to technology and poor internet connection problems. Although the public health services are not available effectively, we international and local government organizations and the DPOs, disabled people's organizations, and CVO are currently running and providing emergency basic food packages as a humanitarian response, delivering standard-based and house-to-house community rehabilitation services, peer-to-peer psychological support services, and providing assistance device to the end user, especially to the poor persons with disabilities and their family members. We all are working together as much as we can through collaboration, coordination, and cooperation under the challenge of COVID-19 and the lowest safe and secure conditions like frequent bulk blasting and limited resources like funding limitation, human resource limitation. As you know, the current situation in Myanmar, most of the audience think that Myanmar is the same of Burma, is that the civil war between an organization and Myanmar military is intensifying, and there are more IDPs and disabled people like us are increasing more than before. There will be more appreciable number of persons with disabilities who are suffered because of current civil war. We could not even provide the existing number of persons with disability effectively in the current situation. Therefore, we would like to request you all to provide more contribution and to involve the rehabilitation and recovery activities of our country. I'm aware that my speech is just for 6 or 7 minutes sharing. I'm sure it will not cover or reflect what is really happening in Myanmar and how we are working, how we are delivering the services. So if you would like to know more about Myanmar, Burma, and the rehabilitation situation, please contact through my email or WhatsApp Burma for further information. Thank you all for your kind attention. Thank you.
Thank you. Thank you so much, and thank you for keeping the time. Our next panelist is Peter Skelton. Peter, if you can reflect on how the World Rehabilitation Alliance plans to support the implementation of the Rehabilitation 2030 initiative, and what would be the place for rehabilitation within the alliance when we think about rehabilitation in fragile and conflict-affected settings. So over to you, Peter. Thanks.
Thank you very much, and good morning, good afternoon, good evening to everybody, and thank you for the opportunity to present. So I'm going to talk about leadership in fragile and conflict-affected settings, but really to focus in on the role of the World Rehabilitation Alliance. And in order to do that, I need to start really by firstly introducing to everybody what the World Rehabilitation Alliance is and what it will become. So it's a WHO-hosted network, and it has a mission to support the implementation of the Rehabilitation 2030 agenda through advocacy activities. So important to stress that this is an advocacy network. The first objective is to conduct evidence-based advocacy activities to increase support and raise awareness of rehabilitation. And the second is to strengthen networking and knowledge sharing within the sector itself by bringing everybody together with a single unified vision. It has 5 key pillars of activity, or 5 key work streams. The first being research, primary care, emergencies, workforce, and lastly, external relations. And each area, each work stream is headed by a steering committee with the co-chairs that you see here in front of you who come from within the community. So we have a secretariat at the top. We then have the steering committee that you've just seen. And then most importantly, there are the members. And hopefully those members are all of you, because members can be organizations, whether they are member states, international organizations, non-governmental organizations, academic institutions, philanthropic foundations, or the private sector. So it's not a network of individuals, it's a network of organizations, all coming together with one voice. There are a number of reasons to join. It's the opportunity to develop advocacy messages together to strengthen rehabilitation within the health system. It's an opportunity to connect and share and learn from other members of the sector. Together, we can widen the scope and influence, not just of rehabilitation, but of the work that your organizations are involved in. And you can also increase the visibility of your own organization through the platform that the Alliance will provide. So for anybody listening who thinks this might be for you, then please do sign up formally to the Alliance. This is the web page here. You can also find it if you Google WHO and World Rehabilitation Alliance, and that will take you to the right place to sign up. So that's the Alliance, but what does this have to do with leadership in emergencies? Well, very briefly, over the last decade, 6.7 million people injured in disasters around the world, and we know that the risks of this are increasing due to increasing urbanization and risks associated with climate change as well. So we have an increasing frequency and increasing number of people injured in disasters. Pandemic risk, as I'm sure everybody aware of, is still relevant. Not just COVID-19, but we've seen with Ebola, with measles, SARS, MERS, all have demonstrated a need for early and ongoing rehabilitation in outbreaks and pandemics. And if we look at what might be coming next, unfortunately, 8 of the 9 current priority diseases of epidemic potential with WHO have the potential to generate significant acute or post-acute rehabilitation needs. So we can't think that COVID is it. Unfortunately, there is more likely to come. Conflicts, as we've heard about,
a growing number of conflicts around the world, and also a recent resurgence after a long decline in mortality and injuries due to conflict. Just some examples up on the page here with pretty incomprehensible numbers. I think really when you look at Syria in particular, 1.5 million over a relatively small, so 6-year time period is just impossible to comprehend in terms of numbers of injured. And unfortunately, one thing that conflicts do alongside other things like climate change is obviously generate displacement. And for the first time this year, we have more than 100 million people around the world displaced. And that is a growing problem. Displacement is important for us all to consider. And this is just a snapshot of why. So this is from a great study by HI and HelpAge, looking at refugees from Syria, and almost a quarter of those refugees had some kind of impairment. So really important to think about displacement as an additional consequence and response need. So from a rehab perspective, what do we need to do? Well, we need to be able to immediately do a couple of things. We need to be able to manage a surge in needs which has been generated by the event, whether that's due to injury or illness from an outbreak. But we also need to be able to maintain essential rehabilitation services in the midst of an emergency. We also, in a number of emergencies, need to do something else, which is an additional add-on, which is to meet the specific needs which are in place due to displacement, and that requires a slightly different approach. Now, where is this relevant? Well, it's relevant everywhere. Every country is at risk of emergencies. But unfortunately, countries that are most likely to be affected typically already have weak health systems, and weak health systems go along with weak rehabilitation services. This is a map of mortality risk due to natural hazards, so earthquakes, cyclones, landslides, floods. And we can see concentrations of mortality a little bit in the Eastern Mediterranean, Central and Southeast Asia, down towards the Ring of Fire, and also Central America over here. If we look at mortality risk due to conflict, we see a similar pattern, but with the addition now of large parts of North and Sub-Saharan Africa as well. And unfortunately, if we overlay onto that density of rehabilitation professionals, although this is only physiotherapists, but it's pretty reflective, we see that in all of those places with the highest risk, we typically have the lowest density of rehabilitation professionals and weak rehabilitation services. And we have a problem. That problem is that despite a huge and growing need and a lack of capacity, rehabilitation is still not a priority in emergency response, particularly in early response and in fragile settings. Why is that? Firstly, there's a lack of awareness amongst decision makers outside of the rehabilitation sector about its importance in early response. There's a misconception amongst many people that rehabilitation comes later, that it's something that can happen after weeks or months of an emergency, not that it's a priority from the beginning, or simply that it's just not a life-saving priority at the beginning of an emergency. We've also found that there's a low awareness amongst rehabilitation professionals of their role. So if we don't understand ourselves what our role is going to be in an emergency, it's very difficult for us to push for it when an emergency happens. But the biggest problem of all is that we are simply not prepared. So when we looked at the data that we have from the STARS assessment, which Sergey was talking about, only 1 in 19 low and middle income countries had any kind of preparedness planning in place within the rehabilitation sector. So there is a huge, huge issue there. So the solution to this ultimately sits in preparedness. But in order to achieve any of this, we need leadership and we need advocacy. So the World Rehabilitation Alliance will try to raise the awareness of rehabilitation professionals and leaders, targeting all hosts of different decision makers about the importance of integrating rehabilitation into preparedness.
Yes.
We'll also advocate where we're in situations where preparedness has not taken place. As an alliance, we should be well placed to advocate for the inclusion of rehabilitation in early response. And Ukraine was a really good example of that, with the professional societies coming together to do that. So we need advocacy, and to do this, we need leaders within the rehabilitation sector, and we need to target leadership outside of our sector as well. But we don't just need advocacy, because we can't advocate unless we actually have the tools to deliver. And so to support that, as WHO, we're working on a few things at the moment. We have a policy brief on rehabilitation in emergencies. We will be developing this year and next year a toolkit for rehabilitation and how to integrate rehabilitation into all hazard emergency preparedness. We have a community of practice for professionals, rehabilitation professionals involved in emergency medical teams. And of course, the Alliance. And this is where you're all very, very welcome with the message, many voices, one message. Thank you very much.
Thank you. Thank you, Peter, for these comments and for sharing the goals and objectives of the Alliance. And we really urge everyone to join the Alliance, because this is a platform where different stakeholders from different sectors can come together and move towards a cohesive goal of integrating rehabilitation into health systems. We are running short of time, but we wanted to take a couple of questions. Chiara, I would like to request you to respond to a question on data. One of our participants shared that how challenging is it to obtain data on unmet rehabilitation demands in low and middle income country settings? So if you can reflect on it, you have about 1 minute, 1.5 minutes to respond. Thanks.
Okay, thank you. That's a key question indeed. What are the difficulties in measuring unmet needs? Well, there are more and more tools to measure unmet needs in rehabilitation. For example, we do have a rehabilitation needs estimator tool that is now available through the WHO, which is based on estimations at the population level, looking at the health trends of population, so aging, non-communicable diseases, and the impact that they have on function. So there is more and more agreement around also the definition of what we mean by rehabilitation need. But of course, this still requires a lot of tools development and making those tools available with actually leaders in countries to collect data. There are also tools around the identification of needs at the system level, like situational analysis, STARS, like ATA-C for assistive technology at the system level, or the rapid assessment for assistive technology needs that look at the needs of ATs. However, using these tools always require commitment and engagement of authorities and multi-sector also actors to gather, to join efforts, and then to make the results visible and be shareable with the decision makers. So there are more and more tools, there's more and more consensus. However, more will and advocacy also is needed to use those tools. It's not an exhaustive answer, but I hope it provides some inputs.
Thank you, Chiara, for highlighting the importance of data, which is crucial for decision making and to inform the process and the policy development that's important when we talk about such complex issues. Another question that we have is on what actions are required to incorporate rehabilitation in primary healthcare settings. We haven't really directly talked about this particular topic in today's webinar, but I would like to invite Peter Skilton to respond to this, and other panelists and speakers are also more than welcome to respond to this question.
Thank you. So I think, first of all, we need better evidence, and this always comes down to the need that we have for research and for evidence in order to justify these things, particularly around our effectiveness and our cost efficiencies, I think, that we can bring. We then need advocacy. because I think there's a lack of understanding about the role of rehabilitation in primary care and exactly what it is and how it can deliver. There's a need for guidelines, and from our side, so WHO are working on a basic package of interventions, so rehabilitation interventions that can easily be rolled out in the primary care setting. And the last thing is the biggest challenge that we always have, which is workforce capacity. And obviously that can be generated through all of the other areas, which can build up to try to help improve workforce, but we need trained, competent workforce to be present in those places. And in most countries, we simply don't have that at the moment.
Thanks, Peter. Do any of our other panelists or speakers want to share any of their thoughts on data and the use of data and the unmet needs around rehabilitation? Great. So in the interest of time, probably, just wrapping up this conversation, first of all, on behalf of the ReLAB Consortium, I would like to thank our speakers and panelists for their time and for sharing valuable insights with us on leadership in rehabilitation. We have established that rehabilitation is an essential service which needs systems thinking and a multi-sectoral, person-centered, holistic approach. This is much needed in today's complex and fast-changing world. However, the political relevance of rehabilitation and the leadership is still needs to be established. We need strong leadership to help transform health systems with the commitment to integrate functioning as a health outcome alongside mortality and morbidity. The surge of rehabilitation needs during and after the conflict doesn't find an adequate response. And that's because the local health systems are overwhelmed, they're damaged, they're destroyed, and there is significant understaffing. Therefore, we need rehabilitation leadership to be responsive to these specific needs and challenges to provide quality and inclusive rehabilitation services in fragile settings and in conflict-affected settings. It's important for us to note that leaders doesn't mean the policymakers and decision makers. It involves leaders from multiple sectors, included but not limited to rehabilitation professionals, allied health workers, health professionals, community level influencers, and the users of rehabilitation services. Together, we have the potential to foster meaningful change. This is even more critical in fragile and conflict-affected settings because we have a lot more national and international rehabilitation actors engaged through their leadership structures to provide an effective coordination between the services and while adhering to the local guidelines and the referral pathways. Data in this is very crucial to help support the decision-making process for all the sector leaders. We have an ambitious but a very fundamental agenda ahead of us, which is to promote rehabilitation as an essential service to achieve universal health coverage and to achieve the global goal on sustainable development. We need to work cohesively to strengthen health systems to provide rehabilitation services to those who need them and where they need them. I would like to thank all of you on behalf of the ReLAB Consortium for joining us today, for your questions, and for being a wonderful audience. We hope to be connecting with you. Please make sure that you are following us on our Twitter and on our Facebook page, and please make those conversations interactive. Thank you so much. Take care and stay safe.